the topics. So first I'll be discussing on acalculous cholecystitis, stress ulcer prophylaxis. So acalculous cholecystitis. So cholecystitis, we all know it is due to gallbladder stones, acute inflammation of the gallbladder due to stones present, gallbladder outlet obstruction or either a cystic duct, a stone in the cystic duct or in the gallbladder. Acalculous cholecystitis is something that does not happen due to a mechanical blockage of the gallbladder. So it is mainly due to hypokinesis of the gallbladder wall, which results in not incomplete emptying uh, or retention of the gallbladder content, which forms a hyperdense content or a sludge. Okay, this is a form of cholecystitis caused by dysfunction or hypokinesis of the gallbladder emptying. So this usually occurs insidiously. It is a life-threatening disorder. It can result in perforation and necrosis also. When we look at to the epidemiology, it is almost 10% of acute cholecystitis and most common in male. Okay, more likely to develop acute cholecystitis after surgery and increased rates in immunocompromised and patients with retroviral illness. So what is the pathophysiology? It is mainly due to bile stasis, increased lithogenicity, so increased bile viscosity due to fever. So we can look into all of these precipitating factors, dehydration, shock, sepsis, all these conditions will lead to a kind of ischemia to or decreased blood supply to the gallbladder wall. So there is, and also absence of prolonged oral feeding can result in absence of cholecystokinin induced gallbladder contraction. So this is the main mechanism. And thereby there is microvascular occlusion in the blood vessel supplying the gallbladder and hypercoagulability. Microthrombus can occur. So that is the main mechanism or pathophysiology. Risk factors when we look into diabetes, HIV, any patient in ICU, shock, on mechanical ventilation, sepsis, drastic weight loss, especially patients who are on TPN, burns, any vascular disease, prolonged periods of starving. So these are the main risk factors for acalculous cholecystitis. So I already talked about the pathophysiology. So use of vasopressors is another concern or is another mechanism. So use of vasopressors decreases blood flow, gallbladder wall ischemia, thicken gallbladder wall, which later becomes gangrenous. Okay, so all these factors, volume depletion will result in increased bile viscosity and highly concentrated bile salts. Prolonged starvation can cause absence of cholecystokinin-induced gallbladder contraction that will result in bile stasis, distension of gallbladder. Okay, so what are the clinical features that the patient can? Any patient who's been on ICU with some new onset fever, you will have to make sure you'll have to do a POCUS and see if the gallbladder is distended or not. So that is one thing you will have to remember. So not all patients are going to be awake and conscious and complaining of abdominal pain and elicit a right hypochondrial tenderness. So it requires a high degree of suspicion in the ICU. Okay, so if the patient is conscious, right upper abdominal quadrant pain, high bilirubin, cholestatic pattern, that is ALP and GGT will be elevated, fever, right-sided pleural effusion, patient can become hemodynamically unstable also. So what are the pathogens that that you need to consider while starting your antibiotics? So E. coli and Enterococcus, two main important organisms, along with Klebsiella proteus and bacteroids. So investigations, abdominal ultrasound is the usual modality that we do at the bedside. And if not, abdominal CT. Okay, always send in blood cultures. So radiological features, there will be gallbladder distension over the gallbladder distension will be there, wall thickening more than 4 millimeter, pericholecystic fluid, and intramural gas can also be appreciated. The three main features would be gallbladder distension, wall thickening, pericholecystic fluid. Okay, intramural gas can be appreciated if there is a gangrenous or necrotic features. Okay, and sometimes if the gallbladder is already ruptured, there will be a free wall and fluid collection in the gallbladder fossa. Okay, a sloughed mucosa, and then inside you will be able to appreciate the hyperdense bile sludge. So other most important investigation that can be done, but normally it's not available in every place, but you'll have to theoretically know this is the HIDA scan. So what is the HIDA scan? That is technetium labeled hepatic immunodiacetic acid scan. Okay. The technetium labeled dye is injected into the is injected IV, and the presence of isotope is not detected in the gallbladder after 4 hours. So there must be some sort of obstruction. So this actually denotes the absence of gallbladder contraction. So this HIDA scan is important is another important investigation that can be done. So how will you manage these patients? So appropriate hydration, send out blood cultures, start antibiotics, and then what you can do is you should always involve a surgeon, or you should attempt to, if the gallbladder distension and the ALP is rising, patient is becoming unstable, then you should consider drainage. So which modality is better? If the patient is clinically stable to undergo a cholecystectomy, either open or laparoscopic, you should consider that. Patient who are unstable, and unstable patients, you can consider a percutaneous cholecystostomy drainage of the gallbladder by a interventional radiologist. Other than that, the other option would be stent placement through ERCP, which can help decompress the gallbladder. So these are the various modalities of approaching acalculous cholecystitis. Complications that can occur are GB rupture, peritonitis, and septic shock. So that is about acalculous cholecystitis. Next topic, we'll be looking into stress ulcer prophylaxis. So almost all critically ill patients are at increased risk of developing erosions and ulceration of the mucosa. Okay, the exact pathophysiology is not known, but it is mainly due to splanchnic or GI hypoperfusion. Okay, most of the patients who are in shock and volume depleted will have GI or splanchnic hypoperfusion. Mucosal ischemia or disruption leading to decreased mucosal secretion, and there will be increased acid production as well. Okay, because of stress. So 75% of the critically ill patients who do not receive stress ulcer prophylaxis will develop ulceration. So what are the three categories of patients? Three categories of stress ulcers. So category 1, stress ulceration with occult bleeding. So with occult bleeding, fecal sample will be positive for the GUAC positive test. So this test detects the presence of occult blood. So the incidence is almost up to 50% can have a occult bleeding. So with overt gastrointestinal bleeding, that is visible, that is clinically visible bleeding, hematemesis or bloody nasogastric tube aspirate or melena. So that can be there in almost up to 8.5% of the patients. So with clinically important gastrointestinal bleeding is something that we are more worried about. So what is considered clinically important? That is overt gastrointestinal bleeding plus one or more of the following. So there will be a visible clinical bleed along with one or more of the following within 24 hours. So either a decrease in the systolic or the mean arterial pressure, or a diastolic pressure of more than 20, orthostatic hypotension, that is systolic blood pressure more than 10, or postural tachycardia. So your drop in systolic blood pressure from supine to upright position. So it will be more than 10, postural tachycardia, hemoglobin drop more than 2, and requirement of 2 units of Paxils and need for vasopressors. So these are the three categories of stress ulcers. Who are the patients who need stress ulcer prophylaxis? They categorize into major and minor risk factors. So any patient who is on mechanical ventilation more than 48 hours, including extracorporeal life support. So not all patients in positive pressure ventilation more than 48 hours need, if you have already started the patient on enteral feed, okay? So positive pressure ventilation more than 48 hours without any enteral feeding or any extracorporeal life support like dialysis or ECMO. So that, and coagulopathy, platelet count less than 50,000, INR more than 1.5, APTT more than 2 times normal. A history of gastrointestinal ulceration or bleeding in the past year. History of any traumatic brain injury or spinal cord injury, burns. So these are the major risk factors, and burns more than 35% of the body surface area. Minor risk factors is sepsis, ICU stay more than 1 week, GI bleed more than 6 days, any glucocorticoid therapy more than 250 milligrams of hydrocortisone or equivalent, use of antiplatelet or NICDs, hepatic failure on renal replacement therapy or any renal failure, peptic ulcer disease, extracorporeal life support, and any organ transplantation. So these are minor risk factors. If any of the two minor criteria are present, that is an indication for stress ulcer prophylaxis. So we looked into the pathophysiology. Most of the time it's not known. Hypovolemia, pro-inflammatory state. So all those things will decrease the splanchnic perfusion. And also use of vasopressors is another concern. So because of this, there is reduced bicarbonate secretion, increased acid back diffusion, decreased gut motility as well, decreased splanchnic blood flow, which results in ulceration. So what are the agents that can be used? Proton pump inhibitors, H2 receptor blockers, sucralfate, and antacids. Sucralfate is something that is going to coat the ulcer, or it is just going to be a barrier. It is not going to neutralize the pH. So you should remember this is not going to be effective. Antacids, aluminum hydroxide and magnesium hydroxide, 10 to 20 ml 4 times a day. So that is also not going to be effective. Okay, it can help in increasing the gastric pH to more than 5. So normally it's around 3.5. So if it can increase it, but the effect is not going to be sufficient enough, or the studies have not shown any kind of great benefit with the antacids. So next is ranitidine, 150 milligram twice a day. Pantoprazole is something what we normally use, 40 milligram uh, per day. So either oral or IV. So what are the concerns with the different agents? The proton pump inhibitors are considered to be more effective agents, but the problems with the proton pump inhibitors are risk of nosocomial infection and C. diff. Okay, and the problem with histamine receptor antagonists are it is more safer, but it is not proven to be so much efficient as the proton pump inhibitors. Sucralfate acts as a protective barrier. It does not suppress acid. Okay, it does not suppress the acid. So infectious complications more with PPI. So we already saw pneumonia, Clostridium difficile, and other hospital-acquired infection because of alterations in the gut flora due to gastric acid suppression. So also it affects the nutritional aspects like malnutrition due to decreased absorption of magnesium, calcium, vitamin B12, osteoporosis can be there, and other electrolyte imbalances. So what does the guidelines say? So indications, we have looked into major and minor criteria. So if the indications are there, you need to start on stress ulcer prophylaxis. Preferred agents, proton pump inhibitors, if you're concerned about the infections and other side effects. H2 receptor antagonists are reasonable alternatives. How long you should continue? As long as the risk factor exists. Okay, and infection risk management, yes, if the patient has any infections, you will have to manage it accordingly and consider stopping the inciting agent. Complications, infections, electrolyte, nutrition deficiencies. So these are the things about stress ulcer prophylaxis. So what does the study say? So there are two studies, the SUP ICU study and the peptic trial. So both the studies have shown that proton pump inhibitors are kind of effective in controlling GI bleed in the patients, and the infectious complications, there is no increase in incidence of infectious complications. The composite endpoint of nosocomial pneumonia or the C. diff infection between PPI and placebo is always almost the same. There is no increase in the incidence. So these are the two trials, and also a meta-analysis did not show any rise in infectious complications. This meta-analysis was a comparison between proton pump inhibitors and H2 receptor blockers. The recent study, revised in 2024, so it found this study showed that the proton pump inhibitors are more effective in decreasing the GI bleed in mechanical ventilated patients in the ICU. So the agents of choice is going to be proton pump inhibitors.